feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Welcome to the National University of Singapore Yong Loo School of Medicine Healthy Longevity webinar. Thank you for joining us. Dr. Natalia Mitin is our today's guest speaker. We will talk about, cellular senescence, one of the hallmarks. I'm sure that this will trigger many questions. Please use the Q&A function to send them. We are starting, as always, with a short presentation, this time by Jessica Liu, a PhD student at the National University of Singapore. And she will present a practical guide for selecting continuous monitoring wearable devices for healthy adults.
Thank you for the introduction. As mentioned, my name is Jessica, and I will be sharing about a practical guide that we developed for selecting continuous monitoring wearable devices for healthy adults. Digital health comprises a wide array of technologies, including mobile health, wearable devices, and telehealth services. Wearable devices offer us the ability to gather objective, consistent, and continuous data on vital signs and mobility, such as activity levels and heart rate, providing insights into our daily routines and behaviors. Some notable examples you may already know include the Apple Watch and Fitbit activity trackers, the Abbott Libre continuous glucose monitor, and the Oura Ring, which is known for sleep monitoring. Currently, several challenges hinder the selection of wearable devices. Firstly, the sheer abundance of options available on the market can be overwhelming, making it difficult to know where to start. Additionally, navigating the selection process becomes even more daunting when trying to find the right device tailored to specific monitoring needs, such as sleep tracking or activity monitoring. Moreover, existing guidelines may have limitations that impede their practical application in the selection of wearable devices, further complicating the decision-making process. We noticed several gaps in our examination of existing literature. Current frameworks and guidance primarily emphasize theoretical principles, useful for understanding why, but not how to select a device effectively. Additionally, a systematic approach is needed to prioritize criteria or factors for consideration, ensuring that various user needs are adequately addressed. Furthermore, existing guidelines predominantly target medical devices or technology for clinical or research settings, overlooking the specific context of selecting wearable devices for use by healthy community-dwelling adults. Therefore, our guide was to bridge these gaps by developing and presenting a practical guide that offers a systematic approach to selecting continuous monitoring wearable devices for healthy adults. Next, I will describe our process for developing the practical guide, aimed at bridging theoretical advice with actionable steps. Drawing from guidelines such as the U.S. Food and Drug Administration, the Clinical Trials Transformation Initiative, and the Electronic Patient-Reported Outcomes Consortium, we ensure that the criteria included in our guide are both relevant and applicable. Additionally, we incorporated insights gleaned from feasibility studies and comparative analyses on device performance found in the literature, encompassing factors such as verification, validation, acceptability, and usability, among others. Our practical guide comprises of 5 core criteria designed to offer a comprehensive framework for assessing either a list of devices or a single potential device. The overarching goal of our guide is to help researchers, healthcare professionals, and device users streamline the decision-making process and facilitate informed choices. The first criterion is continuous monitoring capability. On one side, we have traits of less than ideal devices, and then on the other, we have features of more optimal wearable devices. Continuous monitoring is the first criterion because it is important to ensure uninterrupted and consistent data collection, which can enable a thorough understanding of an individual's daily life and behaviors. The second criterion is device availability and suitability. This factor aims to optimize the device's lifespan and its logistical compatibility with daily use. Key considerations include the device's availability, whether it's the latest model or a minimum viable product, and its suitability. Factors such as invasiveness, bulkiness, and potential interference with daily activities are pivotal, as they directly impact the practicality and operational aspects of using the device. The third criterion is technical performance of the device, accuracy and precision. Validating each measurement, such as heart rate, sleep, and activity tracking, is crucial for ensuring the collection of reliable and high-quality data. This forms the foundation for generating accurate insights into physiology and behavior. Using validation studies conducted with gold standard devices, such as polysomnography for sleep staging, and leveraging tools like the Cosman risk of bias tool are recommended to appropriately evaluate a device's technical performance. The fourth criterion is feasibility of use, designed to optimize user experience and encourage high adherence by prioritizing device user-friendliness. It encompasses two key categories: parameters related to user experience and those to usage in research and clinical settings. This criterion is important as factors like user acceptance, device usability, and data relevancy significantly influence the success of monitoring initiatives. Additionally, it addresses the specific monitoring requirements within research and clinical environments, identifying devices that can seamlessly integrate into workflows. Finally, we address the costs involved, including those for the devices themselves, the management systems, and the subscription fees, to ensure alignment with financial constraints and optimize economic value. In conclusion, we have established a systematic approach for selecting continuous monitoring wearable devices tailored for use in healthy adults. Given the rising popularity of digital health wearables, this guide serves as a valuable resource for researchers, healthcare professionals, and device users alike, aiding in informed decision-making aligned with their specific monitoring needs. Moving forward, our focus will be on disseminating the guide and gathering user feedback to enhance its usability. Additionally, we plan to apply this practical framework to select a wearable device from a list of 216 technologies that we had identified in a previously published systematic review on remote monitoring technologies for cardiovascular functions. Thank you for listening, and we hope to see you at our clinic soon.
Thank you so much, Jessica. I think I still need your advice to actually see what kind of smartwatch to use. Let's go from measuring heart rate, sleep, and all the other things to measuring something else, and that's cellular senescence. Dr. Natalia Mitin is a scientific expert on cellular senescence, and she is the CEO of Sapere Bio, a company dedicated to bring clinically actionable measures, what we all want, of cellular senescence and immune function to healthy longevity medicine. She obtained her PhD in molecular biology and biochemistry, both, and with a prior faculty appointment at the University of North Carolina, and works together with major agencies, but also co-workers, including the NIA. We're very proud, Natalia, to have you here talking about cellular senescence. The floor is yours.
Thank you so much for the introduction. And thank you for having me on. The work we've been doing on cellular senescence in longevity medicine. And so as an outline of my talk, so I will introduce you to the cellular senescence, and then we can discuss how Sapere Bio, the company where I'm CEO and the founder, how we measure cellular senescence network, and then go briefly over what the sort of the test that we use in the clinical practice now, what does that entail. And then finally, I will show you how some clinical studies of how we use it in longevity medicine to monitor and optimize the personalized longevity protocols. So first of all, this probably does not need any introduction, but let's get on the same page. So cellular senescence is a biological state of the cell. And what that means is, as we know, that various exposures can induce cellular senescence. These are things that we come across every day. It's your sleep, it's exposure to toxins, medical procedures, your exercise, nutrition. And those changes affect the cell it's still not clear what makes the cell decide to become senescent versus being clear through apoptosis, but and it's an active area investigation. But what happens is there's so much damage accumulating that cell goes through this process called cellular senescence. When cell becomes senescent, that means that the cell can no longer divide. It's resistant to apoptosis, as I mentioned, so it cannot be cleared. And it starts to secrete inflammatory cytokines that start to affect the rest of the body. Cellular senescence, cells that have cellular senescence can also have all sorts of other molecular challenges. For example, they can exhibit telomere shortening, they can have epigenetic changes. So sort of what we know is hallmarks of aging, all these things can also occur in the senescent cells. So those are definitely not mutually exclusive, but they're also not the same thing. And so in the, I mean, again, sort of there's a lot of literature and terminology gets confusing. So I would like to kind of restate what I am talking about. So when I talk about cellular senescence or senescence, sometimes I drop the cellular. What I'm talking about is the process that I just described. So specifically, I talk about senescence that is induced in immune cells, because if you measure in humans, if you measure senescence non-invasively in immune cells in blood, you're not only capturing senescence of the immune system, but also that is a surrogate for organismal aging, has been shown in basic biology models. Senescent cells, because they secrete cytokines, they can induce senescence in healthy cells, in the location of previous senescent cells, and also in distant sites. Overall, and I think that is a really important point. So overall, even in sort of in older population, there is only in any given tissue, only about 1 to 5% cells become senescent. So the senescent cells are very, very, very few, and yet they're quite detrimental. So cellular senescence has a dual role. And therefore it's really tightly regulated. So on one hand, it provides a tumor suppression role, so it prevents tumor growth. But on the flip side, accumulation of cellular senescent cells can promote aging. Senescent cells, our body is smart. So senescent cells can be cleared by the immune system. And that's sort of the recent findings in the last couple of years. We've sort of kind of starting to discover that. So it's still very active area of investigation. And then finally, cellular senescence is not the same as immunosenescence. Immunosenescence refers to a specific set of changes that occur in the immune system that sort of involve thymic involution, skewing of myeloid and lymphoid lineages. Those phenotypes affect immune system function and therefore it affect, for example, immune clearance, but it's not the same term. So when papers refer to senescence of immune system, you have to be clear whether it's a cellular senescence or immunosenescence, and that's where things get a little confusing. So I will be talking about cellular senescence. So again, as I mentioned, since cells are cleared by the immune system, and basically that is the system that this is the way we think about measuring cellular senescence. So cellular senescent cells can accumulate and then get cleared by the immune system. So you can, so generally there is this balance between the accumulation, between the induction of senescent cells and clearance. And so as you can imagine, there could be situations where immune system is declining and therefore it cannot clear senescent cells, even though you don't particularly have a lot of input into the senescence. Or on the flip side, you can have your immune system may be fine, but you have so much input coming into to make senescent cells that the immune system cannot keep up, and the end result would be accumulation. The important thing is if you measure just cellular senescence, you get a snapshot of what your cellular senescent load is in the body, but you don't get a sense for how you got there, where you are, what is the trajectory. So I think we think that measuring it as a system, as sort of the dynamic system that it is, really provides that insight into actionable sort of potential therapies that can be used, interventions can be used, and then also monitored. And then this is how we apply it in longevity medicine, and I'll address it in a second. So this is the one of the first manuscripts that came out last year that showed that the immune system clears senescent cells. While other cell types, such as NK cells, can clear senescent cells, it appears to be the CD8s CD8 memory cells are essential for the clearance. And so you can refer to that paper. So how do we measure cellular senescence? So we measure cellular senescence with a test that we call SapereX. And I will go into detail a little bit later, but basically, so we measure cellular senescence through certain markers. And the way we report this is we look at where the patient is in the healthy population. So these people do not have chronic comorbidities, so they are healthy patients. And we're plotting cellular senescence load versus chronological age, showing you the sort of the average population trajectory, and then showing you where the patient is, and you can track it longitudinally. And then the same refers to the immune system. We created this immune longevity score, that same reference where you have immune longevity score from 0 to 100. In this case, immune longevity declines with age. So we're showing, and it's gender specific, so we're showing you sort of the trend lines, and then we're showing you where the patient is in the population. So the immune longevity score, so SapereX, basically the overall message is that SapereX, the way longevity medicine doctors use SapereX is to determine how individuals' longevity protocol are affecting their client's cellular senescence and immune function. It's a non-invasive sample collection, so it's a single tube of blood. It's analytically validated and has a precision and reproducibility that is needed to see the changes outside of precision. And it will be commercially available in the second half of 24. So how do we measure individual components? So cellular senescence is measured by measuring P16 messenger RNA, specifically in T cells, and you can refer to the papers by Ned Sharpless, where research was done in his lab that established the system. And as I mentioned, senescent cells in the immune system can propagate the damage, if just an immune system can propagate the damage through the body. And this is a beautiful paper from Laura Niederhofer's and lab that was published a couple of years ago that shows you that. And so again, this is what it would look like. You're looking at cells, so you're looking at total P16 expression in blood in chronological age. So why use P16? So there's thousands and tens of thousands of publications on the use of P16 as a cellular senescence marker, and we find, sort of long story short, we find in blood it's the most reliable measure. So here are the key papers on mouse models that were developed as a hallmark of measuring senescence and then trying to establish efficacy of senolytics. As you can see from title, cellular senescence is associated with aging disorders, and it's associated with function. Here's the work from Andrea's team showing you that, so this is in humans, showing that essentially in every disease of aging you can think of, P16 is expressed in patients who have the disease compared to controls. And then recently, a paper from Morton's lab used a really neat approach where they used the machine learning tool to sort of define senescence by using nuclear morphology. So it has nothing to do with cellular markers. And so when the algorithm reads cellular senescence by nuclear morphology, in those cells that sort of are forced to undergo senescence, P16 and nuclear morphology identification by nuclear morphology, Pearson correlation coefficient was 0.86. So in blood, P16 is one of the best markers of cellular senescence that captures that phenotype. So what about the immune system? How do we do that? So as I mentioned, we developed the score that is called the immune longevity score. And so it's a score, so it goes from 0 to 100, 100 being the most, 0 being the least. So the score was developed the machine learning model was used to power on the outcome called immune resilience. And immune resilience was published in this paper by Dr. Ahuja that you can look at. And immune resilience was defined as resistance to infection and chronic inflammation. That paper, that study had about 50,000 participants in a whole range of cohorts, from normal aging or sort of aging to infectious diseases such as COVID, HIV, HPV, other immune challenges such as renal transplant. So across a whole range of cohorts, they ask the question, functionally, how good is your immune system? So it's a functional readout of the immune system as a whole. And they established these classes where people were immune resilient. So even if they had COVID, they're much less likely to get sick and certainly be hospitalized and resistant to HIV and such. And so we use that measure to establish the immune longevity score. Immune longevity score, so here's the modifiable factors in immune longevity score. Gender is one of them, as I mentioned, that is not modifiable. So these are the modifiable factors. So the way we thought about developing this is we looked at adaptive immune system, and we screened a number of markers, and we identified markers that represent all the key functions of the adaptive immune system. So for example, T cell exhaustion, autophagy inhibition, T cell proliferation, with the idea that if you're capturing functions of the immune system kind of individually as individual domains, then you would be able, when you have an intervention that is working, you would be able to see if there are certain interventions that move certain domains and not others. But overall together, again, sort of for the ease of clinical use, it's reported as immune longevity score, sort of as a composite that you can easily see and then see the breakdown. So how do we know these things are working? As expected, cellular senescence is an early sign of aging, so well before you develop chronic diseases. As you can see from this table, whether you're looking at ILS, so here's the Pearson correlation and the p-value, and here's P16 Pearson correlation and p-value. As you can see that ILS and P16 correlate with early dysfunction. Again, these are patients that don't have chronic comorbidities, so they have some deregulation, but they're not sick. And so you can see that it correlates with heart disease. They both correlate with pulmonary function, kidney function, for example, but P16, for example, is correlated with insulin resistance, whereas ILS correlates with liver function. And so how do we use it in longevity medicine? So first of all, here's the heterogeneity of cellular senescence and immune function. So as you can see from this graph, while statistically there is a trend, it's super heterogeneous. So it is really hard to know who is who, because in any age group you would pick up, the patient could be they could have the least amount of cellular senescence or the most amount of cellular senescence. There is no other clinical presentation that can serve as a surrogate to understand where they are. Same goes for immune longevity score, which was somewhat surprising, but the same goes for immune longevity score, where there is really no way to tell if where the person is until you measure. So to start to address when physicians get report back, how do they start to think about it? So the way we came to interpret this is the patients are divided kind of in 4 groups. So one is your cellular senescence and the immune function are what we call normal, so they're kind of balanced. So your sort of cellular senescence is optimal, and then your immune longevity is optimal. And those patients are balanced. Whatever they're doing for longevity, their longevity treatments are working just fine. So you might not want to change anything. And then you have a cohort where immune function might be fine, but now the cellular senescence is really accelerated. On the flip side, the cellular senescence may be fine, but the immune function is impaired. Either one of those scenarios will lead to the 4th category, where both cellular senescence and immune function are severely deregulated. The senescent cells will secrete cytokines that will deregulate your now normal immune system. And on the flip side, the immune system cannot clear senescent cells, so sooner or later you actually start to accumulate. So in either one of those cases, the intervention may potentially be required, but certainly once you get in a category where both are deregulated, there is no way to normally get out of that state without intervention. And so we use that as a framework to start to understand where the patients are first before you start thinking about interventions. So to give you a breakdown, so this was a cohort of about 500 patients. to give you a breakdown of what that looks like. So if you think of it again in sort of in those domains, so you can have patients who both domains are in balance. You can have people who have high cellular senescence versus deregulated immune function, and you can have domains that are both. And so you can see sort of in the, overall, in a younger group, about 50% people kind of are in this balanced state, which is actually not that high of a number. There is quite a few people who have deregulated immune system, but not as much senescence alone. As you start to progress through the age continuum, you can see that the number of senescent cells starts to increase. And interestingly, as you get older, as kind of you expect, that you don't really have categories where it's just the senescent cells, because both the immune system and senescent cells are deregulated. So you really start to accumulate in this category with both domains are deregulated, and you need to consider interventions. So here are a couple examples. So for example, so here's a couple of patients who have normal immune system. So we tend to think that anything over 40, over the score of 40 is good, and it could always be optimized, but sort of 40 kind of is the sort of seems to be the, the minimum optimum. And so, so while they have a normal immune system, the cellular senescence is really high, and certainly in this patient. And then the opposite is true where you have normal cellular senescence, age-appropriate cellular senescence, but the immune function does need help. And then you can have the third scenario where, you have a third scenario where both cellular senescence is really high and immune function is impaired. So again, this is how we use the categories in the longevity space to try to sort of understand where the patients are and how it relates to the interventions. So so currently, because the test is not available commercially yet, so we have the healthy longevity, healthy aging registry, where we're onboarding clinics in the research sort of setting, and we're collecting. So we're trying to understand a couple things. So first of all, the way the registry is set up is it's a real world registry. So there is no patient preselection. It's completely treatment agnostic. And what I mean by that, it doesn't just mean drugs. It could be patients are doing something about their longevity. It could be that they're not doing anything about longevity. They're taking drugs, they're taking supplements, they're exercise, nutrition, or not. So it's completely real world. And then sort of as they learn about their markers, then they, sort of they can choose to. So again, completely open, completely real world. It makes it challenging on the data analysis, but we believe that is sort of, it provides the real world view of that. So the questions that they're asking in this registry is, first of all and foremost, is can cellular senescence and ALS be restored to healthy ranges in patients who have deregulated levels? So second of all, is our test good enough? So is the analytical precision we have, is it enough to detect meaningful changes? And the answer to that is yes. And so then, as we accumulate evidence, the questions become, what interventions have the best chance of succeeding? So if you think about the matrix of interventions, what interventions kind of float to the top as being the most efficacious? And then because it is a real world and not randomized controlled clinical study, we can also start looking at stacking of the interventions. And so do the interventions that have a good chance of succeeding coupled with something else actually nulls the effect? And so again, sort of that provides the ability to monitor the efficacy, if you wish, of longevity interventions without waiting for the endpoint of longevity in the setting where people already are doing this. So you're helping understand. So as I mentioned, patients who are in the balanced category don't necessarily need to kind of change their longevity practice, at least from the point of improving the cellular senescence and immune function. But again, if they want to, that provides you with a risk-benefit analysis to try to think of the interventions and potential side effects and whether this particular patient population needs it, because they already are balanced. But as you sort of get further, you might consider aging longevity interventions, whether it's on the cellular senescence or the immune front. And here are a couple examples from a registry. So here's the patient who, so blue dot is a baseline visit, first visit, and the green dot is the second visit. So here's the patient who had sort of lower immune function and cellular senescence. So they improved their immune function. cellular senescence didn't change, at least not within the precision. Here is another patient whose, again, immune function improved greatly, while cellular senescence remained about the same. Here's a second case where patients decreased their cellular senescence. In this case, it was already, so to speak, age appropriate, so at least population average, but it could still be improved further. And here is another example. And as I mentioned, because cellular senescence has dual roles, the tumor suppression function of cellular senescence is really important. And so while we monitor cellular senescence and this kind of change would be considered good, you also have to be careful to make sure that cellular senescence does not drop to the undesirable levels. And that is where the risk for the interventions in patients who are balanced for cellular senescence kind of lies, where you can potentially decrease it further. So one important thing to address is and that we always bring up with our clinicians, is that when you think about changes in cellular senescence and sort of the senolytic effect, what we always like to stress is that if the patient report comes back and they have high cellular senescence, when we say the patient has high cellular senescence, under no circumstances we mean that this patient needs to get a senolytic drug, the way they're defined in mice, because there is scarce to no evidence that the senolytic drugs that work in mice work in humans. So therefore, cellular senescence as a hallmark of aging that is connected to other hallmarks can be affected by other things. So senolytic drug is not the only solution. And when we see the senolytic effect, what I mean by that is a change in cellular senescence. So it's a senolytic effect, whether it's direct on senescent cells or indirect through immune system or suppression of inflammation or change in autophagy that senescent cells need. So in sort of the way we look at it, it doesn't really matter what treatment the person is getting. If their cellular senescence is moving in an optimal direction, that is a good thing for longevity, because remember, cellular senescence is not just a hallmark of aging. So induction of cellular senescent cells promotes aging, and then taking senescent cells decreases aging and aging phenotypes and functional decline associated with it. So if you can change cellular senescence in a patient, that causal change in aging will also change, regardless of how you got there, regardless what the treatment is. So this is super exciting. So while the registry is ongoing and we're just starting to collect longitudinal data, what we started to get the sense that clinicians are getting better at understanding how to use SapereX and being able to actually help their patients. And so so these cohorts matched about 1-to-1. And so if you look at in a single clinic, so the same doctor is treating these patients. So if you look at the changes in cellular senescence in patients whose longitudinal visits were before September 2023, about 12% people increased their cellular senescence, about the same amount decreased their cellular senescence, and in most people, senescence did not change. Now, further on, if you look after that, about half of the people increased their cellular senescence, and 3 times as many decreased their cellular senescence. So the ability to see this, and the ability to intervene, and the ability to monitor is making a difference where clinicians, whether they feel more comfortable or sort of they're finding treatments that are more efficacious, you can see the sort of the clinical utility, sort of to use the traditional medicine terms, you can see the clinical utility of SapereX, where now you have sort of the guidance of being able to see the senescence and being able to change the senescence. And so I would leave it here. So this is how we think about SapereX. This is all the opportunities that we think that this can go into, and I will answer any questions.
Thank you so much, Natalia. Great presentation. And of course, I love P16. It's associated with so many age-related diseases and bad outcomes. My first question would be, how do you measure P16? So which kind of technique do you use, and what are the pros and cons?
So we isolate. So we take whole blood, we isolate T cells, and we measure messenger RNA by qPCR. So there are, as I mentioned, there's only cellular senescent cells that represent about 1 to 5% population. So it's a very, very, very low level expression. So it is extremely critical to be able to have an assay that's precise, because that is a huge problem, and sort of variability between lots and between days is a problem. And so the clinical assay is extremely critical for that, when you're treating patients and collecting longitudinal data. So there are some studies where P16 can be measured by protein. So there is a difference between transcript and a protein, and I can sort of send the references that you guys can put in the show notes. But basically, the basic story is P16 transcript is one of the most stable transcripts that exist in mammalian cell. The experiments that sort of are used in the lab to measure the transcript, the cell will die before the transcript turns over. So it is super stable. And the reason for that is when cells become senescent, so they're sort of when they decide they're going to become senescent, P16 normally is not expressed. So when cells decide to become senescent, P16 transcript goes up and it stays up. And the sustained expression of P16 is essential for maintenance of senescent phenotype. So by measuring the transcript, you're basically measuring number of cells that have that transcript, and therefore you can infer the senescent cell load.
And you are isolating T cells out of whole blood for every of the patients. So you first isolate PBMCs and then the T cells, and then
we isolate. It's a very good question. So we isolate from whole blood. So, and we just automated the assay to sort of account for the volume before we launch. So we isolate from whole blood. The key is that the sample needs to be preserved, so the T cells are preserved, because notoriously T cells are not great being shipped around. So we had to develop a preservation solution that now is in a blood tube. So the samples are collected into this preservation solution, and it's stable for days. So it allows you an opportunity to send it to a central lab or wherever the sample is isolated. But yes, basically the T cells are isolated from whole blood, which is a very straightforward process, and then sort of stored for analysis, and then you read from that.
And I fully understand that you're focusing on the wonderful T cells, but what about their peers, their B cells and the monocytes, etc., which has been shown also to express P16, 21, and all the other ones? What is the rationale, and how much do we actually learn about the senescent state of the body, or is it just for the T cells?
So the original papers from Nat Sharpus's lab about 10 years ago, so 11, I guess, at this point, showed that, they took blood and they looked at every population, every blood type there is, right? Blood cell type. And they identified T cells as so expression of P16 in T cells was the marker of aging. So that's what correlated chronological age the best. So monocytes absolutely express P16. They express very small amount of P16 compared to T cells, but there's a lot more of them. So in bulk, they're quite a large component. Monocytes complicate the picture quite a bit because they're extremely variable. And so in blood, it's really hard to capture. It's a very acute response. And then they become really important as macrophages. When they go in tissues and become macrophages, they become extremely, because they hone on sort of other cells. And so that's been very well described. So in tissues, P16 expression in macrophages is probably extremely important as a marker sort of the immune kind of, attack on the tissue. In blood, when we looked in our we have a number of traditional settings, sort of, predicting adverse events in cardiac surgery and such. So when we looked in those settings, expression in T cells correlated with adverse events. Expression in PBMCs or monocytes themselves did not. So again, I think sort of that while it's important, it does not seem to be, the expression in T cells seem to be a cleaner marker. The T cell versus B cell, Ned's lab published on that too, that in mice, the T cells again sort of shows you the aging. The B cell seems to be more the cancer component.
No, I love the approach that it's very clear what you measure. Absolutely. Can you tell us a little bit more about the fluctuation of the number of T cells in blood? And of course, it's fluctuating if we are experiencing an infection, etc., or after a vaccination. But what do we know in relatively healthy individuals who are clients of health and longevity medicine clinics? What do we know about the fluctuation in there with maybe the natural noise we have in our body, because we are just harnessing, I would say, blood to do measurements. And of course, we would love to have, at least lots of other tissues. So what do you thought about the fluctuation component?
So the number of T cells can change, obviously, as you mentioned, with sort of any challenge, right? The senescence does not change. So the number of senescent cells is very stable. So we, as sort of internally, we have donors kind of donating internally program. I mean, we've seen people without any changes for 6 years, and we test every 3 months or so, and it's always the same number. So if you're not actively involved in sort of changing your lifestyle and kind of longevity, what we think of longevity intervention, cellular senescence seems to be extremely stable. The immune longevity score can change because of vaccinations, because of challenges, sort of you're sick, you have COVID, just now you just recovered, or sort of, so that sort of can be affected. So that's a lot more malleable parameter, but cellular senescence, the P16 expression itself, it appears to be extremely stable.
Okay, that's great to know. Also that you have internal data of such a long phase. That's great. One, I would say, a little bit nasty virus lots of us have with us is cytomegalovirus, so CMV, but also HSV, etc. Do you actually test for CMV positivity when you are looking at the senescence score in the clients you have at the moment?
Yes. So our clinics, all the clients have the CMV, EBV, like all the herpes viruses, COVID, all of that. So all of that data is collected, yes. And obviously we see changes. So if your immune longevity score is poor, you are likely to have at least a titer. So whether it's, reactivated or not, but there is absolutely correlation with chronic infection.
Yeah. And then your scores you are giving back. Now I'm talking a little bit as a health and longevity medicine physician. You are giving the scores based on the herpes virus infection state.
So the score. So as you saw on the bottom panel, so the score incorporates T cell exhaustion, T cell proliferation, and autophagy inhibition, gender, and age. So patients who have CMV titer higher than patients sort of who have, basically zero, will tend to have a lower score. So it's a variable, but it's not accounted for. So basically the way you think about this is the report comes back, cellular senescence is normal, immune longevity score is 10. Why? So you as a clinician then go and think about what is it in the patient's history and current medical records can indicate that the immune system is impaired. Is it just they just had infection just now, or is there a potential, do they have a high CMV? So that's why that is a clinical use tool, because it's a flag that clinicians use to go and look further. The people who have, high CMV like active CMV infection, or at least chronic CMV infection, will tend to have high exhaustion. So the individual domains will also be skewed.
Yeah. Fully agree with you for the acute one, but so many do not even know that they are chronically infected and have CMV. It depends, of course, of the ethnicity, how often, but at least half, I think, of the population we're watching at the moment.
95-80%, I think most of us really.
Yeah. Let us go to the registry. I love the idea, because that's what our field needs. We need, I would say, clinically relevant, real data out of the community to see what's going to happen. So I really applaud the initiative. How can health and longevity medicine physicians actually, can they reach out to you to be part of it? How open is it? What's your goal with that registry? I think lots of physicians are watching at this moment in time.
On the website, on the saperex.com website, there is a button that says Early Access Program. And so you can sort of apply. It's a quick questionnaire of, sort of what are you trying to do, how many patients you think you're going to be treating, sort of what your longevity goals are. So it's kind of just to kind of tell us more about it. And then we would schedule the call and then kind of sort of, get introduced and evaluate. So in the broader answer, what we're looking for is we're looking for clinical partners that are thought leaders in the field, and they have capacity to collect clinical data with the variables that we would need to be able, because it is, all the treatment interventions and dosages and all that. So that's there has to be a way for that to be accessible. They're willing to do this with us, and they're willing to think about it, and they're willing to kind of to try treatments that they're doing right now and give us the data for the analysis. So that's it's really can we do this operationally? Do you have phlebotomists in the office? In some offices, there's no phlebotomist, and they send them to in the US, they send them to LabCorp and Quest, and so that's a limitation. So there are a couple operational things that are like little things like that, but for the most part, it's really just is there a scientific and clinical match to join? Because we're it's a research tool that is, I agree, that it's essential to have, but you can imagine how big the registry needs to be before we can actually do analysis, because of complexity of longevity treatments and new ones coming every day. So
yes, that's my next question. So how can you ever then say in this observational approach that it's accurate, or the test? How do you take, for example, lifestyle changes?
Yeah, well, it's not one size fits all, right? It's it's kind of like Audrey de Grey's approach, where you have a matrix. You have some people who have just 2 interventions, some have 3, and they just kind of the matrix loads on top. But also this does not replace randomized clinical trials. This goes hand in hand. So if you find that, let's say, urolithin A is really good for your immune system, or senescence for that matter, because that seems to be everybody who took urolithin A with something else appears to be better, you can go test it. So it's it gives you it gives you insights, but then also it's stacking. So if you take urolithin A is good for everybody, but for people who took it with metformin, now right? So it's a complex registry, and that's why that needs to be large, but it is real world.
Yeah, no, it's fantastic. I would love to connect you to our society, the Health and Longevity Medicine Society. I think lots of physicians would love that approach. I think we can go on and on and on to actually see where it is in the clinical translation. But I see that our audience has lots of questions, so I will hand over to Weilan Wang, our postdoc at NUS. Please.
Thank you, Andrea, for introduction. And hello, Natalia, and nice to meet you. And this is a wonderful talk, and we really get a lot of questions from our audience. So are you ready for the questions?
I am.
Okay, so let's come with the first one, and I believe most of us are really interested in is, I see that in your presentation, around 37 of your clients showed a positive improvement after intervention. So what are the interventions that you can see showed, or let's say have a higher chance to show positive effects on cellular senescence?
We would love to know the answer to that, but just as Andrea and I were discussing, there are so many interventions that the power is just not there to say which interventions work. So stay tuned.
Do you think if there is let's say the most promising or most possible one you would like to investigate more in the future?
There are a few that seem to work. Interestingly, senolytics, what people think of senolytics, don't seem to have an effect, which personally, I'm not surprised, but again, just word of caution of going by mouse data. But it's too early to be able to actually, certainly, to be able to endorse anything, but it's too early to describe.
Yeah, so I think we indeed need more investigation and more people in our field. Then we will get a bigger data set.
Exactly. Well, and it's that, right? Because nobody's doing one thing, everybody's doing all sorts of things. And so to be able to say with confidence that it's, urolithin A and not because else, that will require a much larger data set.
Yeah. So hopefully we'll get there soon.
That's what makes it exciting. We're super excited.
Yeah, indeed. And another question is from our audience and asking, it seems that most of your clients are healthy clients. They have no baseline disease or any chronic disease. So how do you think to expand the measurements of cellular senescence into a larger population, such as people with, of course, indeed, still with healthy clients and also with clients with existing chronic disease or health conditions?
So we've, before we got into longevity medicine space about 2 years ago, we've worked for 8 years before that. We worked with patients who have diseases, whether it's a heart, so disease of aging, it's heart disease, diabetes, cancer, various cancers, sort of, sickle cell disease, those kind of things. And so we have we have thousands of samples from this population, so we understand really well what happens with patients with disease. One thing I would say is that there are clients, these longevity clinics that we partner with, there are patients who have diseases. There are patients who have autoimmune diseases. There are certainly patients who are metabolically unstable. Like it's not, I mean, they might not have full-blown diabetes, but they're, like their BMI is high and they're metabolically unstable. So it's not healthy, what's healthy in 20 is not the same what's healthy in 70. So it's sort of definition of healthy is kind of, what I mean by that is not like, many chronic, but there are definitely patients who have chronic diseases that they come. And actually, that's a really important point, because the way we think about SapereX, it's not diagnosing disease. It's not telling you, you should give this person senolytic, or you should give this person, if the person comes in and they have, they have a flare of autoimmune disease and they are pre-diabetic, you need to fix those first. Senescence can wait. It's not an urgent need. You need to first fix the sort of the things that will lead to disease much faster. Then you can reevaluate and you can think about how you can sort of fine-tune optimize the protocol. So it's definitely not, we can fix diabetes or we can target cellular senescence. Like that's definitely not the choice.
Yeah, and then this will lead to our next question is that how do you think of the association of the cellular senescence in different organ systems? Let's say
so we get this question all the time, and we tried doing work on this, and it's complex so in humans it requires biopsy, as you can imagine, not a fun thing to do, and so we came to the conclusion, and sort of literature supports that while essentially every cell in your body can become senescent, so it's not sort of specific to the immune system, the role of cellular senescence in tissues, the markers that I used kind of is different. So if you induce senescence in the immune system, so Matthew's that paper showed that if you induce senescence in the immune system in a mouse that otherwise does not have senescence in other organs, right? You start seeing senescent cells in the liver, in the kidney, in the heart, and sort of start seeing it in other organs, and your clinical lab then changes and showing that your liver function is declining, your kidney, so it is associated with actual change in clinical parameters. So it's really hard to decipher because this is a mouse model where there were no senescent cells to start with. So when you're looking at the patient and you're looking at senescent cells in a certain organ, if you're trying to target that organ, so from basic research standpoint, if you're trying to develop a senolytic drug to target kidney disease, it's really important to know where the senescent cell came from, what they do, what markers are the best, so you avoid adverse events. All of that becomes extremely critical if you're developing a senolytic drug. From our standpoint, if you're looking at cellular senescence and you're trying to use it as a tool to monitor cellular senescence changes and immune system changes with age, as a way of kind of gauging aging, then immune system is non-invasive testing and is a surrogate. So we sort of tend to kind of gave up looking at tissues because things get complicated and there is really no. The 5 cells in the heart is not the same as 5 cells in the kidney, and so there is no evidence to suggest what is the threshold.
Yes, and exactly. And I think the model training is quite hard, especially when we don't have enough data sets from other organ systems.
Exactly.
Yeah, and here is another question, and in regards to the model trained in your products. So your model is trained the ILS, the immune longevity score, are derived from the healthy patients as let's say all of them. So one question was about will you consider to cluster your data sets into different, let's say with different family history or with different conditions, or in other words, how did you deal with the confounding factors from these confounders?
So we intentionally didn't, because we we decided that the molecular changes we're measuring, such as T-cell exhaustion, proliferation, autophagy inhibition, will tell us that the confounders work. So for example, so as Andrea was asking, so if somebody has CMV or ABV or sort of viral infection, we do see association of ILS, and that was on that slide with sort of early, the table with Pearson correlation coefficients. You do see CMV association with ILS. So yes, if your CMV titer is high, you will have worse ILS. One thing to note is, and I think that's important, so when we say ILS score is 0 to 100, that means that, so the way immune resilience works is the class we're looking at is a great immune resilience, where you're resilient to infection and you don't have chronic inflammation. There are other classes where you get worse and worse and worse. So our score predicts the how good of the resilience there is. So when we say ILS is 0, it doesn't mean you don't have immune system. It just means that you're not resilient. So there's sort of, we're kind of measuring the ability to bounce back essentially from infection and resist inflammation, which is, part of aging. And so we've seen people with, with various challenges and people undergoing surgery where those numbers can change. So it is, so we're like, gender seems to be the confounder we cannot adjust by molecular markers, but otherwise we do see correlations. I mean, again, it's in humans, right? So everything is a correlation, we can't prove it, but we do see correlations with things that would make sense, that are immune challenges that would make sense, including COVID.
Thank you. And due to the interest of time, here we will have the one last question for you from our audience. The decrease of cellular senescence after intervention is due to the increase of proliferation of new cells or high apoptosis of senescent cells, or do you think it's the reverse of senescence phenotypes to a younger cell?
So senescent cells are cleared through apoptosis essentially, so they're not going back into healthy tissue. So they're just taken out. So it's hard to say whether senescent cells, so the way the senolytic is supposed to work is you basically unveil the system, you allow immune system to see it, and then it clears it, and then cell undergoes apoptosis, or you block because they're resistant to apoptosis, so you block that. So in our system, we cannot tell whether it's the senescent cell was cleared in a true senolytic fashion, where you targeted actually cell, or did you improve your immune system, you suppressed inflammation, so now immune system can see the cells because it's not distracted by infections, it can now see the cells and turn them over. So we can't separate the two. The timelines where the intervention makes, we see intervention working could be anywhere between 3 months and 8 months. So it's probably not a super direct response because it takes a few months. So we think it's still via immune system, but we don't have any sort of evidence for that.
Yes, understand. Thank you very much.
Absolutely.
Thank you so much, Weilan, to handle this very nice discussion. And thank you so much, Natalia, for this great presentation. I really love the idea to now measure the senescence load with P16 in the patients. And I think you will have great success. Thank you so much. You as audience, please give us hints who you would like to see as speakers. Use the chat function to have your ideas, your comments, your suggestions. Leave all your ideas with us. We are currently recruiting for the ORCID study. What is it doing? We are evaluating the oral microbiome of community-dwelling individuals living in Singapore. So if you are living in Singapore and you're interested to participate, please donate a little bit of time to complete a short survey and a little bit of saliva. That's what we need. Register using the QR code and we will be in touch with you soon. We will close this webinar with a short final video. I can only say that muscle matters. Take care.
mind. Like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.